I would be talking about ocular chemical burn management strategies. I have no financial disclosures, but chemical burn can present to you in acute to chronic stage in variable stages, as well as in variable grades of involvement of the limbus as well as the adnexia. But the basic principle of management remains the same. The patients in the acute stage need to be managed with a globe-saving surgery. In subacute stage, you need to focus on managing the control of the inflammation. And in the chronic stage only, which is about 6 months to a year later, you would be thinking about visual rehabilitation. You have a lot in your armamentarium today as an ocular surface surgeon, as a cornea surgeon, to be managing at any stage with one or many, a various permutation and combination of one of these procedures. In cases wherein you have a severe grade, a moderate or a severe grade of chemical burn with any of the acid, alkali, any of the chemical burns, the role of amniotic membrane transplantation is absolutely indispensable, and it has been shown in number of studies, and there has been a fantastic study with Namrata ma'am leading the study wherein they have shown even the umbilical cord serum works far better than even amniotic membrane and autologous serum in acute stages to give you a very nice epithelialized surface in eventually on these patients along with the medical management. However, you would have patient in which you could have much more severe and deeper burns with molten iron, etc., wherein there is not only a chemical but a thermal factor which has worked on the patients, which will involve not only the limbus and the ocular surface epithelium, but you would also have the involvement of the sclera in terms of the ischemia. This is something which is in otherwise a very good work by Dua's classification, wherein the Dua's classification works very well for most of your patients of chemical burn, wherein the conjunctival involvement was included along with the corneal epithelium loss to know the prognosis of these patients, but it could not actually define the limbal involvement in otherwise a very well graded system for a severe form of ocular burns. It is where we have done a lot of work, and this was the published work in Journal of Cornea, wherein we actually followed patients of scleral ischemia from acute to chronic stage, and we actually proved that in patients with no ischemia, the number of cases in which in chronic stage who lead to hypotony and perforation were far more than patients of scleral ischemia, wherein in patients of scleral ischemia, there were a large number of perforation and hypotony as versus in patients of no ischemia. And if you would rehabilitate these patients with one of the limbal stem cell transplant procedures and follow up these patients, you would have actually far larger failures in patients wherein ischemia was present versus in patients of no ischemia. Hence, to say that actually dealing with not only the epithelialization and the limbal involvement in these patients is important, it is very far important to actually do treat the scleral ischemia with procedure called as tenonplasty. There are less papers on tenonplasty, but the procedure primarily involves removing all the necrosed epithelium, whether it is on the corneal or the conjunctival epithelium, and you would notice that the conjunctival epithelium is far more thickened in patients with scleral ischemia, and this white edge wherein you have no blood vessels actually seen needs to be removed from the ocular surface, and you need to pull the tenons from the periphery wherein available, whether it's 360 degree or whatever number of clockas that you see the ischemia. It is very important that you pull in this tenons 360 degree, suture it with your 10-0 nylon at the limbus, and you actually cover it with the amniotic graft and do a tarsorrhaphy along with medical management. I would not run through whole of the video because of the time that we have limited here. But primarily what I wanted to show you here is that tenonplasty works very, very well in patients wherein you have scleral ischemia, can be globe-saving surgery, and in long term can be the only procedure that could be saving and giving vision to these eyes. However, in patients wherein you have total limbal stem cell deficiency, you have been able to save these eyes and they are unilateral with mild to moderate symblepharon, the procedure that works very well, and as Dr. Jodhbir had also mentioned in his talk, is SLET. I think SLET is not very new now. We have been talking about it over 10 years now. It has given remarkable results, and long term also has given fantastic results. The procedure primarily involves taking a limbal biopsy from the good eye of about 1 to 2 mm size, depending upon the amount of clock hours you are working of limbal stem cell deficiency. It is actually cut into small pieces, and it is transferred to the eye which is affected, wherein the limbus is, wherein the pannus is removed from the ocular surface, and where you can put an amniotic membrane onto the ocular surface with the glue and cut these small biopsy pieces and transfer it to the affected eye.
Just one second. Can you connect the laptop, please?
Can you just reconnect? Till the time they are connecting, I would just go back to tell you that the procedure of SLED primarily involves taking the limbal biopsy from the good eye and transfer it to the affected eye. And by taking 10 to 12 biopsy pieces, you can actually get a very nice epithelialized ocular surface. It's not coming there? Absolutely, and I would agree with you. Yeah, so we are back, and I would go back to my presentation. I'll take that question later. But where we were that in patients of unilateral chemical burn, where you have limbal stem cell deficiency, SLET is a procedure which works very well, and you would have a very good epithelialized surface, and you may be lucky to have a clear cornea below. And over a month, it has been shown that only SLET may be able to give you a very good vision. We were a part of the multicentric study as well. We had our own published literature, wherein we actually published long-term results with SLET, and you can have about 70% good visual outcome and anatomical outcome in patients of unilateral burn with SLET itself. You could have patients, like we were talking about, patients wherein you have scleral ischemia and you have grade 5 ocular burn with molten iron burn, etc. You could have not only just a a poorly epithelialized corneal surface, which has a progressive LSCD, but you could have symblepharon also, which you will be dealing with. And these are the patients who have severe grade of symblepharon along with limbal stem cell deficiency. Herein only a stem cell transplantation in the form of SLET would not work, and you would actually need to do a successive surgery of dealing with the symblepharon, later on doing a SLET. And this is a patient which is an example wherein we later on did a penetrating keratoplasty followed by a cataract surgery and had excellent results. We did publish our results of penetrating keratoplasty in patients wherein SLET were done for unilateral ocular burn with limbal stem cell deficiency. You would have less choices in patient where you have bilateral limbal stem cell deficiency and you do not have an area from which you would be able to take a biopsy for, like in patients you have unilateral LSCD. Herein you could take a chance of doing a live related allo-SLET, and with our short-term for our short-term patients that we have followed up, we have not published our results. Live related has worked better than patients of cadaveric allo-SLET, but they require immunosuppression, and we give almost 2-drug immunosuppression to this patient, but there are no standardized immunosuppression regimens of patients for allo stem cell transplantation. You could have patients which go beyond the management of the usual team, and this requires a very comprehensive, a very close-knit team to work on patients which are as severe as this. So this was a patient, I just spotted this attention because this was a patient which required a multidisciplinary approach in a center where we had multiple doctors working together as a team for patients, wherein a bilateral grade 6 burn was presented with a 360-degree scleral ischemia and bilateral corneal perforation. It was taken up for emergency. We did a bilateral therapeutic keratoplasty with a tenonplasty and AMG in the acute stage. Later on, it was a skin graft was done by the oculoplasty person to do a tarsorrhaphy, and in such a patient, the only way out for them for a visual rehab is a keratoprosthesis. The patient was lucky to have a wet ocular surface wherein a collar butter type Boston type 1 K-Pro was done. This procedure is very similar to a penetrating keratoplasty, except that you have the graft which is sandwiched between the anterior and the posterior plate of the K-Pro, and you could combine it with the Ahmad glaucoma valve, primarily because they have very high incidence of glaucoma in these patients. So these are the patients in which only on long term, on 2 to 3 years, close follow-up, would you be able to save their globe and give a good vision to them with the Boston keratoprosthesis, which later on also requires a very close follow-up. You could have patients like this where even your hands as a corneal ocular surface surgeons would not be enough, and you would require a plastic surgeon to form their lids before you're able to go inside and go ahead and do a visual rehab, either in the form of a limbal stem cell transplantation or a Boston K-Pro. This is one of the patients where we have now a 2 years follow-up, and this patient is doing well with the only eye that we can see with a lid formation which was done by one of the plastic surgeons. To tell you, if you have the long-term follow-up of the literature that you would see on chemical burn in which K-Pros have been done, you would have issues like glaucomatous optic neuropathy, retinal detachment and trauma, and progressive ischemic optic neuropathy, which you would be dealing with and would require a close follow-up. To conclude my talk, I would just like to say, for good outcomes in ocular burn, in acute stage, it is very important to follow the principles of management and do a timely intervention to save the globe and manage the inflammation in these patients. And for chronic ocular burn, SLET works wonderful for unilateral LSC. It has over 10 years of follow-up now with SLET. Allo-SLET would have good short-term outcome, but require immunosuppression, a very good patient's follow-up with you. And Boston K-Pro works very well for wet eye, except that you would require, again, a very good close team to work on these patients. With that, I would just like to thank my team at Shoff and also the stem cell lab people who are working with us for the stem cell work that we are doing at the stem cell lab at Shoff, and with which also I would like to invite you to this global summit, which is in October 7 to 9, and we are expecting great participation from world over and great speakers there from 7 to 9. It's an online meeting. Thank you, Namrata ma'am, once again.
Thank you so much,
and
Nidhi. It was indeed wonderful. Can I have Professor Tityal speaking on ultra-thin desecking CHED? I'm very sorry we could not take up any questions now because there's lots of
time is very less.
Thrust and pressure coming from the posterior segment colleagues who are coming right after this.
They are already there, actually. Doesn't matter, they are there to manage it.
Okay. Thank you, Dr. Namrata, for a kind invitation, and Ajanta for making this beautiful session for the evening. Today I feel honored speaking in front of my retina colleagues, which we hardly get an opportunity like this where they can listen to us, see our surgeries also, and I'll be fortunate to listen to them today also. It's a rare opportunity, and thank you, Ajanta, for making this type of combination.